Today we will be discussing about acute bacterial meningitis in infants. Okay. So, what is the purpose of this particular presentation is you should know what is acute bacterial meningitis, the etiology, clinical features, and the differential diagnosis. Then, how to proceed with the investigations and management, followed by preventive method and public health aspects of meningitis caused by bacteria. So, meningitis is inflammation of the meninges that includes pia mater, arachidoid matter, and dura mater. So any infection that is caused by bacteria is called as bacterial meningitis. Okay. So in this bacterial meningitis, it is caused due to the infection of cerebrospinal fluid. It is actually a life-threatening emergency in infants due to their immature immunity. Now, the epidemiological part. So, it is most commonly affecting infants between 1 to 5 months of age with no sex predominance, and the most common agent are Streptococcus pneumoniae, Haemophilus influenza, and Neisseria meningitis. The peak season include winter and monsoon season. So coming to the etiology, in case of early onset meningitis in neonates in E. coli, then gram-negative bacilli, Klebsiella pneumoniae, Streptococcus agalactiaceae, Streptococcus pneumoniae, Listeria monocytogenes. Then in case of late onset, again same E. coli, Klebsiella pneumoniae, Enterobacter, Salmonella, and Staph aureus can cause. 1 to 3 months, again E. coli, Klebsiella pneumoniae, Enterobacter, these common things occur in addition to that Neisseria meningitis and Haemophilus influenza type B. In case of 3 months to 5 years, which is most commonly affected age group, again Streptococcus pneumoniae, Haemophilus influenza B, Neisseria meningitis, sometimes rarely Pseudomonas and Salmonella typhi. So what are the risk factors? Risk factors include poor socioeconomic conditions, poverty and overcrowding, recent colonization and pathogenic bacteria, then close contact with a person having the invasive disease. Then if there is any defect in the specific host system like a complementary defect in C5, C18 or preporidin defects. Then T cell defects, especially this is quite commonly associated with Listeria infection. If there is any splenic dysfunction or congenital or acquired CSF leak, okay, then lumbosacral, dermal sinus, and meningocele. So these are all the risk factors for meningitis. So how do this occur? So just to cut short it for the UG level. So usually it starts with an nasopharyngeal colonization, then bacteremia occurs wherein the said bacteria mix up with the blood, followed by an invasion to the cerebrospinal fluid, wherein they release a cytokine there and then resulting in cerebral edema and neuronal injury. The clinical features include fever, irritability, and poor feeding. This is the most common form of presentation in infants, associated with lethargy, vomiting, and myalgia, sometimes arthralgia, then high-pitched cry, then bulging anterior fontanelle, and seizure or altered sensorium. So the clinical features in case of late and some specific features include neck rigidity, Kernick sign, Brudzinski sign, cranial nerve involvement of 6, 7, and 8, and then papilledema. So neck rigidity is not present in 100%, it is present in more than 60% of the patients. So what is Kernick sign? So Kernick sign is when the knee is flexed to 90 degrees and the hip is flexed to 90 degrees. When, then the extension of the knee is painful or limited in extension. So this causes further proceeding in this direction causes pain. So that is what we call it as Kernick sign. Brudzinski sign is a passive flexion of the neck. It will elicit a hip and a knee flexion automatically. So this is what we call it as Brudzinski sign. Now coming to the investigations, the basic investigations include CBC, which will show neutrophilia, then CRP procalcitonin, where it will be elevated. Blood culture is diagnostic, and a lumbar puncture for CSF examination is indicated unless otherwise contraindicated. Now, coming to the differential diagnosis, in case of viral meningitis, there will be mild clear CSF, encephalitis, focal deficits will be there, and abnormal EEG will be present. In case of TB meningitis, it will be subacute in presentation associated with lymphocytic CSF, followed by increase in protein. Cerebral malaria parasite will be present. And in case of sepsis and encephalopathy, no meningeal irritation will be there. So this will be the most important chart that you have to remember when dealing with a meningitis case. The normal includes a pressure will be 28 centimeter of H2O. There will be 75% lymphocytes in neonates, and then protein will be in 20 to 45 milligram per deciliter, and glucose will be greater than 50. So based on glucose, in case of bacteria, it will be decreased. Same with the TB meningitis, and it will be normal if it is partially treated. Or virus. Only in mumps you will see increase. As far as protein is concerned, it will be exponentially increased in TB, and then increased in almost all. Wherein in case of viral, it will be mild increase. Pressure will be much elevated in acute one and usually elevated in TB. And leukocyte count, the polymorphonucleocytes will be there elevated in acute bacterial meningitis. Same is the case with the partially treated one, and it is happens rarely in viral meningitis. And in case of TB meningitis, it will be 10 to 500 in number with the predominance of lymphocytes. So the bacteria, the findings of the CSF will be it will be turbid in case of bacterial and clear in case of viral and opalescent in case of TB. Neutrophil count will be there and there is a mild protein rise, whereas there will be very high protein rise in TB. Low glucose will be present both in bacteria and TB, that is acute bacterial infection and TB, whereas it will be normal in viral. Coming to the management, hospitalization is immediate as it is an emergency situation. Again, stabilizing airway, breathing, and circulation is important. You have to start with empirical antibiotics. So once you admit the patient, you secure the line, then start with IV antibiotics. And once you admit the patient, you immediately send the blood sample for culture. So manage a raised ICP, that is intracranial pressure, and seizures if present. So ICP will be usually present. Seizures will, if present, it has to be managed. Coming to the empirical antibiotics, if it is less than 2 months, ampicillin plus ceftoxim, and if it is greater than 2 months, ceftriaxone plus ceftaxime and vancomycin. Dose of vancomycin is 60 mg per kg body weight, and if listeria is suspected, add ampicillin. And coming to adjuvant and supportive care, some textbooks say about dexamethasone. It is debatable, but you can give in the very first time you inject antibiotics, and then mannitol or hypertonic saline to manage ICP, anticonvulsants if seizure is present, and then antipyretics, nutrition, and IV fluids. So the complications include cerebral edema, subdural effusion, hydrocephalus, disseminated intravascular coagulation, then deafness, motor deficit, cognitive delay, and behavioral issues. So there is a 5 to 15% mortality is there, 20 to 30% sequelae is there. And these poor outcomes are usually associated with delayed therapy or a pneumococcal meningitis. And fortunately for us, we have our national immunization schedule, which provides Haemophilus influenza vaccine in the form of penta vaccine, where dose is given at 6, 10, and 14 weeks. PCV 13 or 15, it is again given in 6 and 14 weeks, and 9-month booster dose for staph pneumoniae. Then meningococcal outbreaks are usually caused by this Neisseria meningitis, and BCG is given at birth for prevention of TB meningitis. So coming to the summary, so this is a pediatric emergency, and timely diagnosis and antibiotics prevent death. Vaccination and awareness are best prevention. Always remember, every bulging fontanelle is a cry for help. So act before the brain suffers. So thank you for listening to this lecture. Hope you have learned.